Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening to everyone, and welcome to an event I think is extraordinary this tonight because for many reasons. We've me and Dr. Hani thought to give you something more broader, rather than just something focused. We're going to discuss atrial fibrillation and NOAcs in general because I think this is a week of NOAcs. Everyone is discussing that. But we thought from Inr Monitoring Society we'd like to do something really of general education to everyone, and I hope will be beneficial to everyone. And it's open, so we can ask any questions, any comments. We don't have the answer, but we try to, entertain together the discussion education. So I put some slides together. I think it's cover everything we need to know about NOAcs as a journey. I think this has been there with us for a long time now, 9-10 years. We learn a lot. We failed sometimes, but I think that's not I don't call it a failure, I call it a feedback. So let's, I call, the first slide I call, we are today COVID doctors. I think there's no any borders among us, no hierarchy anymore. As everyone is humble doctor learning. I think COVID made us really to be really humble. All you remember this, who passed away is a doctor in China who announced about this COVID, and since then, we've been not really restricted with our movement and our activities. A lot of things changed, our communication, and you can see this webinar is an example of that kind of education we do. But I think we discovered this, webinar. It's maybe a future. I think it's we're learning. Maybe sometimes one-way communication, we try to make it more interactive, inshallah, in the future. Right, I thought, we start with a case, and I want to my colleague, Dr. Hani Sabbo, all of you know, our electrophysiologist and highly in the field of education, and today he's this is the area. So we'll go with this patient, who 56-year-old male smoker, heavy smoker for a long time, with the traditional risk factors. We're all aware, there's sometimes you see a whole event on hypertension. So we have somebody with hypertension 5 years, and type 2 diabetes for 6 years, and we expect somebody with type 2 diabetes, they will have macro, micro, and this patient already had macrovascular primary, had a coronary artery intervention 6 months ago, and now a few days ago atrial fibrillation. So young, we can't say he's very old, young man, and then examination, patient is kind of obese, blood pressure not bad, rest of the examination, bit of crackles, maybe sign of heart failure there. We go to next. So medication, you can see patient on a medication which goes with a patient who had a stent, should be on antiplatelets still within 6 months, or sometimes go for a year. We'll discuss that later on. A patient on beta blocker, on dual antiplatelets, and the medication for you can see for diabetes, which is up to date, and this goes with the guidelines and new guidelines. And if you look at patients' labs, patients, there are area of improvement, maybe in terms of HbA1c, maybe in terms of patients' LDL even further. Maybe we can improve patients' microalbuminuria. Ejection fraction is low. So patient asking you, what's going to be my management, having this new electricity and problem, is this something a part of, we have not maybe addressed some of my risk factors? Is it because of my hypertension? Is it because of my diabetes? Is it because I'm getting older? Is it because of, I'm not adhering to medication? So there are many questions goes in the mind. And today is focused on atrial fibrillation and prevention of the stroke and further vascular. So Dr. Hani, are you with me? Can we have Dr. Hani?
It's right here.
Yes, so let's just have your thoughts on this patient. If you go back here, what things this patient's, concern, of course, the new thing is atrial fibrillation, but patient got, lots of risk factors and vascular problem. What do you think? What are your thoughts on this patient?
So there's a lot of potential treatment interventions that we can do from this patient, from the non-pharmacological to pharmacological to device PCI. So we really have to look at this patient in a very broad eye, as you mentioned. So the first thing is that the guy has AFib and a history of coronary artery disease. So could this be a manifestation of worsening LV function, atrial remodeling and dilatation? Could it be due to restenosis, instant restenosis? Certainly he's diabetic and he doesn't have to have chest pain. You could have the restenosis occurring silently with AFib developing. And the third thing, of course, is that AFib is always adverse in these patients with LV dysfunction. We know this from the Framingham study.
Yeah.
So we have to do something about the atrial fibrillation. And this would be a classic patient that would be enrolled in the Castle AFib study, right? So LV dysfunction and atrial fibrillation. So I think in this patient who's young, multiple comorbidities, we have to look for the initial strategy. What are we going to do in the hospital? How to prevent heart failure, long-term, rhythm control possibly, and then optimizing the medical therapy from multiple different points. So his rate is actually reasonably controlled, 77 beats per minute, okay? His blood pressure is probably a little bit higher than I like for a patient who has LV dysfunction, okay? His BMI is elevated, so there's some issues here with his treatment, and he obviously has a little bit of lower limb edema. So
the voice is gone. Is it from?
Yes, very important point.
Here?
Thank you for saying that.
I don't know if Mu'taz or everyone can hear me at least.
Can you hear me? Yeah, I can hear you, Dr. Abdullah. Clear. So we have, I think Dr. Abdullah's video is frozen. In the interim, I can, I think he's resetting. So common errors in clinical practice is to attribute.
We are hearing you, doctor.
Is that you can attribute mistakenly the lower limb edema to the calcium channel blocker. Now we also know the calcium channel blockers are not entirely useful in patients with LV dysfunction. And the patients on an ACE inhibitor. Okay, assalamu alaikum. This is Hani Sabur. I'm sorry, until Dr. Abdullah Shahab gets there's a little technical issue. I'll jump in with my little section. So what I wanted to talk today, and I think it's also one of the things that Dr. Abdullah wants to do also, is we want to talk about practical scenarios with the NOACs or the direct oral anticoagulants and how we can encounter some clinical utilization. So if we have time, we wanted to discuss NOACs in STEMI, ACS, and PCI, NOACs in the peri-procedural settings, and NOACs in patients with CKD. So we'll start with NOACs in MI and ACS, and after PCI, we'll try to get some insights from randomized clinical studies and evidence-based medicine. So AFib in the post-PCI patient or the coronary artery disease patient overlaps a lot. 70 to 80% of all patients with AFib have an indication for continuous oral anticoagulation therapy, and coronary artery disease is about a third of the patients presenting with AFib, and 21% of patients who have a PCI or a CABG overlap. And patients with ACS can develop AFib anywhere between 6 to 21% of cases. And as you know, the CHADS-VASc score includes coronary artery disease as part of the risk stratification for stroke prevention. 5 to 7% of patients undergoing PCI either have AFib or have other indications for oral anticoagulant. And with the AFib, about 2% of European population, about 2 million anticoagulated patients may be having a PCI or having a stent. So there are basically 3 major groups of patients who have AFib and undergo PCI. So the major points are this. If we have patients who have had a coronary event or a chronic coronary syndrome who've had a PCI, this number is going to increase. As we follow these patients more carefully and the patients are aging more, there are greater rates of both CAD and AFib as well. In addition, 8 to 10% of our patients undergoing PCI have AFib, and in Asia and other countries, the numbers can increase even further. And antithrombotic therapy in the post-PCI patient is sometimes not well defined. So we've now had the advantage of the Augusta study and the Entrust AF study that actually tell us that there's a lot of bleeding that occurs with triple therapy, which then makes the prognosis and mortality a lot worse. Oh, Dr. Abdullah is back. Welcome back.
It's carry on. It's okay, fine. Yeah, as I say, this discussion around AF. So you're discussing the PCI and AF?
Yes, Augustus and Entrust and Redual. So the management, of course, therefore represents some clinical difficulties, especially as the patient gets older and they're more prone to bleeding, and they're also more prone to having stroke and more likely to have coronary artery disease. So at this point, these are the challenges, right? You have atrial fibrillation, in which NOAcs are currently the standard. We have warfarin still present, and in very, very few patients, antiplatelets. The points here that are important is the risk of stroke balanced against the risk of bleeding, patients with impaired renal function and specific older subgroups, how to monitor, and of course, reversal and cost. When you look at the CAD patients, so either they have had an ACS, they've had a PCI previously, or a CABG, the question, of course, is using aspirin and antiplatelet therapy, novel P2Y12s, and how much NOAc can you use? Can you use 2 or 3? So they're overlapping. And then, of course, the question of what dose, if you're going to use dual or triple antiplatelet therapy, what kind of stent does the patient have, and the duration of antiplatelet therapy, likelihood of bleeding, and of course, some subgroups. So there's a lot of complex interactions here, which makes the what's we call the art of medicine or precision medicine or personalized medicine, like Dr. Abdullah mentioned in the first situation. And remember that the guidelines come from clinical trials that excluded patients who had other diseases and other indications. It was purely atrial fibrillation, whatever background therapy they were on. So a lot of this is going to be extrapolation, but we've recently had the advantage of a couple of randomized clinical studies that have highlighted this particular patient group with its overlap. So these are the clinical questions that are being answered. So anticoagulant therapy, due to thrombosis in the left atrium, it's very clear that anticoagulation is better than antiplatelet therapy. In PCI, it's obvious that we have high shear stress, narrow vessels, branching arteries, platelet-mediated thrombosis in the arteries. Dual antiplatelet has for decades shown superiority to aspirin alone. Now, if you add both anticoagulant and dual antiplatelet, this is what's known as triple therapy. And this clearly is going to increase your bleeding risk. How do we know that? It's kind of important to realize that bleeding itself after PCI or in the ACS patient increases mortality, right? If you bleed in the setting of acute MI or you've just had a stent, what's going to happen? You may go into hemorrhagic shock. Anemia predisposes to inflammation. If you stop the antiplatelet therapy, stent thrombosis will occur. So it's really important to try and avoid bleeding in that critical period right after PCI or in that window where the patient has a vulnerable stent. So compared with patients without bleeding, those who bleed are much more likely to die, not only early in the hospital and also late after discharge, largely because of this vicious cycle of bleeding triggering multiple different pathways, and particularly discontinuation of antiplatelet therapy in the vulnerable period. So these are the randomized clinical studies that have looked at AFib, PCI, and triple therapy. So the first one, of course, was the WOOST study. WOOST study did not look at NOAc, but it actually looked at warfarin with aspirin, with clopidogrel, either in dual or triple combination. The next one was the Pioneer AF PCI, which was Rivaroxaban. Then we had the Redual PCI, which was the Bigatran. We have the Augustus PCI study, which was presented last year in ACC. And of course, we have the most recent one is the Entrust AF PCI with edoxaban. Again, all of these patients are receiving various combinations of OAC and antiplatelet therapy. So the first study was the WOOST study. This is the oldest, and this is what triggered the thinking how we can manage these patients. Small study coming from one single center, but it's very valuable. 573 patients, 2013. So there were patients who were randomized to dual therapy or triple therapy, okay? So 1 month minimum if they had a bare metal stent, 1 year after drug-eluting stent in both, okay? And the triple therapy was OAC with clopidogrel, OAC plus, and this is warfarin, of course, clopidogrel plus aspirin, okay? The primary endpoint was all bleeding events, not an ischemia-driven study, followed up for 1 year. Secondary endpoints were combination of stroke, MI, thrombosis, and target vessel revascularization, so efficacy, but primarily weighted on bleeding. Fairly obvious, what are you going to get? You know this even without looking at the slides. Triple therapy group had almost double the amount of bleeding as the dual therapy group. However, the difference in death MI, target vessel revascularization, stroke, and stent thrombosis was increased, but not as much as you would have expected. And the biggest concern was, if we drop one of the antiplatelets, are we going to lose the efficacy aspect, and do we get more stent thrombosis? So in fact, the significant reduction of major bleeding with no significant increase in thrombotic events with triple therapy. Okay, so there is a difference, but the important point was that the in-stent thrombosis did not significantly increase. In fact, most of the deaths were driven by bleeding. So if you looked at the effect on terms of the individual endpoints, of course, bleeding was clear, and that's any bleeding. All-cause mortality was higher in the triple therapy arm, but MI was not significantly increased. Target vessel revascularization and stent thrombosis were not significantly increased. So this is very reassuring that by deleting aspirin, we're not losing the efficacy endpoint, and we're not actually causing a lot of difference in terms of stent thrombosis, which was everybody's fear. However, the major bleeding was significantly reduced. So this is really a trade-off that we can accept. Next, we have the Pioneer study with Rivaroxaban. This, of course, is one of the most complex study designs that I have seen in the last 10 years. And basically, they had different doses of Rivaroxaban, different doses combined with clopidogrel alone, combined with aspirin and clopidogrel, or aspirin alone. And there were three arms, primarily Rivaroxaban 15, reduced dose Rivaroxaban, and warfarin as well. So it essentially was copying WOOST, also Atlas, and triple therapy. 2,100 patients with Afib and prior coronary stenting. Again, the primary endpoint is a bleeding endpoint, not an ischemia endpoint. And the creatinine clearance patients who had a creatinine clearance between 30 and 49 instead of 15 were actually reduced to 10 milligrams. I just want you to remember that. It's a very specific dose that we don't use a lot in clinical practice. So the 15 milligram Rivaroxaban was actually tested in a couple of clinical studies, in a small number of patients in Rocket Afib, and in the Xanthus real-world study, and also in the Pioneer Afib study as well. The bleeding was defined as major, minor, and any bleeding requiring medical attention. 15% of bleeds actually required medical attention. So what do we see here? So the group that had the lowest risk of bleeding was, of course, the group that did not include triple therapy. So this is P2Y12 plus Rivaroxaban. Okay. Slightly above that is Rivaroxaban reduced dose with dual antiplatelet, and the highest, of course, is warfarin with dual antiplatelet. So I think we could have sort of imagined that this was going to be the answer, but there's a really tremendous difference in the risk of bleeding. It's almost a 41% relative risk reduction, which really gives us pause to think we're not really missing anything with aspirin at this point. This is sort of additional proof of that. So the dose, on the other hand, of 2.5 milligrams with dual antiplatelet therapy, as you can imagine, in the light pink here, had an absolute risk reduction of 8%. Unfortunately, this dose is not approved in atrial fibrillation, right? So that puts us almost back to square one. We're testing a dose that now we know works in the COMPASS study for vascular, but it does not work in atrial fibrillation for stroke prevention, right? So I think, therefore, the general consensus is the best outcome is, in fact, the 15 milligram once a day plus the single antiplatelet therapy, having the lowest overall risk of bleeding. And very important, the study was not powered to show superiority or any kind of outcome endpoint in terms of the MACE, but they were all very similar. So again, the suggestion is we're not losing any of the efficacy, but we are definitely improving the bleeding endpoints as well. And stent thrombosis, which is the concern of most interventional cardiologists, was not significant. So, sorry, did this, yeah. So we'll just skip these. There are a lot of limitations. The trial did not have power for efficacy, but again, the dose of antithrombotic therapy is a commonly used dose. The use of the specific doses of Rivaroxaban, 15 and 10 milligrams, were used and have some indication in AFib, but not the 2.5 milligrams. Redual PCI is a little different. This is a study of dabigatran 150, dabigatran 110 versus warfarin with triple therapy. Now, the two dabigatran arms only used a P2Y12. There's no aspirin. Aspirin was exclusive to the warfarin arm as well, again, driven by bleeding events. And just to save some time, the effect of any group that contained warfarin with triple therapy significantly lower with dabigatran 110 and dabigatran 150. Okay? So it's obvious that we have a significant advantage, which we now know for a fact, with the use of dual therapy, P2Y12 with dabigatran at whatever dose. And of course, you would basically select the dose based on your estimation of risk. ISTH major bleeding, TIMI major bleeding was also significantly reduced. And of course, the most important one, which we fear all the time, is intracranial hemorrhage. Far fewer events with the dabigatran dual therapy than warfarin triple therapy. Non-inferior in terms of the composite endpoint, no difference in terms of stroke, systemic embolism, or revascularization. Stent thrombosis, again, no difference with any dabigatran arm. Now this, we've basically deleted aspirin in this group of patients. Last two we have is the Augustus study. So Augustus study was a very clever design. I'm going to share it with you. Here, a larger number of patients was randomized, 4,600 patients. Warfarin on one arm, apixaban 5 milligrams BID, and selected patients 2.5 milligrams based on the weight, age, and renal function. So 2 out of 3. Okay. Now these patients were double-blinded to placebo, aspirin, placebo, aspirin. Okay. P2Y12, of course, was required for at least 6 months. So we're not getting rid of the P2Y12. Has-bled scores were high. CHA2DS2-VASc scores were actually higher than the Aristotle study. Good use of ticagrelor, 6.2%, but mostly clopidogrel. Many patients with qualifying index event, elective PCI 1/3, ACS and PCI 1/3, and no PCI in another. Significant reduction in bleeding, 31% reduction of bleeding. If you took the aspirin away, you actually had almost a 50% reduction in bleeding. And the group that had this arm here was the lowest group, that's aspirin, apixaban plus placebo. But of course, you have apixaban plus aspirin is the 13.8%. So the good news is that with that, we are getting a significant reduction compared to warfarin and a significant reduction even with the aspirin group included. The ischemic outcomes, again, were definitely in favor of the apixaban-based arms, so stroke and hospitalization. Again, stent thrombosis not significantly increased. So the clinical implication is in most patients with AFib, recent ACS or PCI, apixaban plus clopidogrel without aspirin is the preferred antithrombotic regimen, and regimens that include warfarin plus dual antiplatelet therapy should be avoided at this time if possible because of the increased risk of bleeding and no specific benefit in terms of outcome. And last but not least, the Entrust if we don't have edoxaban here, but I believe it's going to be here very soon. They actually used a reduced dose of edoxaban, 60 milligrams. The standard dose of edoxaban is 90. And we have P2Y12 inhibitor without aspirin in this group, and P2Y12 inhibitor with warfarin and aspirin for a shorter period of time. Again, significantly high has-bled scores to begin with, typical of the general population. No surprises here again. The edoxaban arm had a significant reduction in the bleeding endpoint. And of course, this is important because the INRs were also very well controlled. So they had a very robust study group. The time and therapeutic range was 63.1. So it's very good, robust endpoint here. So if you take all of these together, in terms of bleeding, you have Augustus, Entrust, Pioneer, Redual. All of them favor NOAc with dual antiplatelets. So in other words, NOAc with a P2Y12, much in favor to warfarin with triple antiplatelet therapy, with triple antithrombotic therapy. And there's almost a 40 to 50% difference in that confidence interval. And all of the other analyses, if you take them all together, stroke is not significantly increased. All-cause mortality is actually in favor of the NOAc dual, and MACE events not in favor, and stent thrombosis not significantly increased. There's sort of a wide confidence interval here that does not reflect increased stent thrombosis. However, bleeding is without a doubt significantly improved. MI is no different, and stent thrombosis is no different. So very important to realize that the new strategies may require aspirin briefly for the first 1 to 2 weeks, and then you're going to have your NOAc plus clopidogrel based on the period of time that the stent is exposed. So we're not really losing much in terms of triple antiplatelet therapy, but we're certainly gaining a lot in terms of bleeding. And with that, I'll stop and I'll come back to Dr. Abdullah, and maybe we can discuss that case.
Okay, great. That's fantastic. I think you've really discussed what I was going to, support the case we had. Just go back to our case again. So you see the case?
Yes, clear.
Right. So basically, what Dr. Hani showed you, my colleague here, is that the patients, if we're focusing on atrial fibrillation, we're trying to prevent the stroke. Then we had at least 4 randomized clinical trials to support us with the effectiveness and safety and efficacy of the dual, which is here we're talking about NOAc plus clopidogrel in particular. We're not talking about the new antiplatelets here. So rather than going with the 3, not going like aspirin, clopidogrel, and NOAc. So it's better to go with the NOAc and clopidogrel here. So that's the recommendation, at least for 12 months. Then after the 12 months, we go to only NOAc if patient remain in atrial fibrillation. And during the hospital, that's I think the discussion is, how long should I continue the aspirin? Is it only until patient discharge or until 30 days? Because there's a sub-analysis of one of the randomized clinical trials showed those who had less than 30 days of aspirin had a trend, not significant, but trend that they might have risk of ischemia, stroke here, and stent thrombosis. For example, instead of but at the expense of bleeding. So still that area is still not clear. What do you think, Dr. Hani? That area is not clear. How long do we should go with aspirin?
So I think the realistic or pragmatic approach is probably we're going to continue aspirin for about 2 to 3 weeks after the procedure, right? Mm-hmm. Because we've seen that in Augustus and in Trust, right? This is sort of the really hypercritical period. And in fact, even before we had these randomized clinical studies, the guidelines were saying minimum of 4 weeks, right? So we know that that's sort of the critical period. After that, I think all of the risk falls off and you just have more bleeding. So I think this is not going to be known, but I think this is how we have to sort of accept some trade-off. One other important point is that, if you look at these clinical studies, they have, they're comparing to warfarin, right? This is comparison to warfarin. Of course, the biggest problem with warfarin, within the first 2 weeks, you're not going to be therapeutic. You're still building up the dose. The patient's on low molecular weight heparin. So the distinct advantage of NOAc, it's immediately on. You have the entire effect, and therefore the initial increase in bleeding that you get from overdosing of warfarin or whatever you don't get with NOAc. So I think this is probably the 2 major sort of gaps in the evidence, but I think we can definitely say that 2 weeks of triple therapy is probably reasonable at this point. Maybe the first week after the procedure and then the second week on the outpatient basis.
So the question here is, in a recent study in Denmark presented in ESC 2019 showed patients self-managed warfarin therapy was associated with lower risk of a stroke in AF patient rather than NOAc. What's your opinion? So this is one colleague asking Dr. Ahmed am I not? I think asking us. So what do you think of that? Dr. Hani, did you hear that question?
So sorry, I didn't quite get the question. Well, what was it?
Saying, the patients who are, the study, recently, 2019 at least, it says that the patients who, who had self-managed with warfarin had lower stroke and AF rather than NOACs. I've not seen the study, but
okay. Yes, I think this is relating to the home monitoring with INR, right? Using the home monitoring at home and then just utilizing an algorithm or calling a nurse practitioner or a doctor for guidance. So this is actually fairly robust data that we know from the era of the valve trials. Okay, so the home monitoring of INR allows the patient to do at least a weekly INR check, so the gap is much reduced. And also, because the patient is directly involved in the measurement and so on and the discussion, I think it becomes a very useful way of doing that. So unfortunately, even in the United States, home INR monitoring is covered by insurance only for mechanical valves, which is unfortunate because the number of AFib patients is larger than the patients with mechanical valves. Okay, but I think we have Thiqa and Daman here actually covers the home INR monitoring, the strips and the device. I think it's a very cost-effective strategy to lower the risk of stroke and bleeding if you have to be on warfarin, right? Because there, the issue is no longer an issue of coming to the hospital, waiting for a blood test, getting an answer. No, it's an instantaneous thing. The patient does it as if they're doing their home glucose monitor. They check their lab, they call in, or they know within a certain range to stay, or if there's a question, they call a nurse. So that's, of course, in Denmark. Denmark has a very, robust support system and a very good program of medical education and so on. And if you remember the 3 NOAc mega trials in Denmark, the time and therapeutic range, Denmark, Sweden, and so on, the time and therapeutic range was well over 80%. So I think that's unique to their system. But I think if we can provide that to the patients, of course, it's an excellent strategy. Yes.
So you see that normally the guidelines like 2-3 years behind. I think these guidelines came after maybe Pioneer, but not Redual, and maybe some aspect of it has been addressed in the guidelines. You can see really focusing on bleeding and ischemia, those who are at risk of bleeding. And, we try to, as experts say, shorten that triple therapy as much as you can, because the bleeding is, the risk of causing mortality similar to the ischemia is no different. That's why the whole idea of NOACs is to reduce that bleeding aspect of warfarin, because warfarin is swinging INR, that's causing the problem. You get kind of not stability of that thinning blood with the NOACs. And just going back, whole idea of NOACs, because we went to so focused area intervention, and not to forget atrial fibrillation. We lived like 70 years with warfarin, long time. We never thought of, to one day to have a drug, which is as simple as NOACs, expensive, but really, if you look at the interaction of diet and medication, not there. Short-lived, and now we can also have an antidote for it. And these are randomized clinical trials, look at efficacy and the safety, and all showed, at least equal in terms of, efficacy, at least. Maybe some of the medication even better in terms of efficacy. But in terms of safety, much better the NOACs. And that's, speaking about the intracerebral hemorrhage, which is lesser, than the warfarin, and that's what we fear about when we start patient on. Dr. Hani, you don't remember, anytime we want to start patient on a warfarin, the first thing we are worried about patient causing harm to the patient. We are with the physician. We try to, not to cause harm first. Safety. That's why safety is really stop lots of medication. If you can see in the, lots of nice medication being stopped because of safety issue. So really, NOAC showed that to be of great value. And but remember, we have a patient here who has got diabetes, hypertension, had PCI, atrial fibrillation, but this patient at risk, Dr. Hani, at risk of having, need a device, need a surgery, might have accident in future. So take us through that, Dr. Hani. What happens to these kind of patients?
So, in the course of life, there are many unpredictable items. And in fact, when we had warfarin, we always used to convince ourselves if something happens, we can use fresh frozen plasma, vitamin K, or factor 7, or whatever. I mean, we always had this sort of theory in mind that we could somehow resuscitate the patients. But of course, since NOACs have been there's a very important paper from Dr. Majid in 2014, also from Denmark, which showed that in all accidental or emergency room or CCU visits or whatever, patients on warfarin routinely did worse than NOACs. And remember, in 2014, there was no reversal agent for NOAC. So reversal agent for NOAC is more like an airbag. It's in the car. You never need it until you need it, but you're not likely to have it because the cars now are so safe and they have radar and warning systems and so on. So in this setting, so this particular patient, he developed new onset of atrial fibrillation, right? The patient ultimately will require an ablation. I think he's a very good candidate for ablation. The patient may have sixth sinus syndrome, may require an ICD if his LV function remains low. We didn't say he has a left bundle. Maybe he needs a CRT. Or the patient's sitting on his NOAC doing fine, and then he has, coming, to make sure he doesn't get stuck with the curfew, he drives fast and he has a car accident. So in this situation, the NOACs provide two different safety features. First of all, the risk of bleeding is generally reduced. Second, they have short half-lives. So even if they end up in the ICU and you resuscitate them with bleeding, if they have bleeding, but some of them will require immediate reversal, okay? So maybe the patient has a pericardial tamponade, or the patient has to go for an immediate PCI, or the patient has a hip fracture. So the reversal agent becomes important in these unusual scenarios where an immediate procedure has to be done within the window of 12 hours. Because remember, even the ones with the longest half-life, like the Bigatran or Apixaban, the window is still 12 hours. If you can wait for 12 hours, then the half-life is 50%, and you can probably take the patient to surgery in that. But if it's a much more urgent surgery and you need to do something within 3 hours, then reversal agents become important. So this is unique. There's two different sets of reversal agents. So Adexanet alpha is still under clinical trial, has not been available, but we have had idrosizumab, which is the specific reversal agent for the Bigatran in the UAE now for the last 2 years. And I think all of the major hospitals should have it, especially the trauma centers and the transplant centers and what have you. We haven't really had to use it, to be perfectly honest. It's there. If you need it, it has a very quick effect. It basically reverses it's a monoclonal antibody, binds all of the Bigatran in the circulation within 5 minutes. So that if the patient needs to go for major surgery, within an hour, they can achieve complete hemostasis. If they have to have neurosurgery, they have complete hemostasis. If they have to go for PCI, there's no drug in the system. If they have to go for a heart transplant, there's no drug in the system. So you can eliminate the drug and then redose again. Hopefully, we will get the universal reversal agent. It's from a small company called Portola that covers all of the other NOACs, but that's still not available at this point.
Well, quick answer. Patient require cardioversion. Do you have to wait for, again, 3-4 weeks, or we can do it because of quick onset of action? And
sure.
Do you have to wait for long? I mean,
sure.
So, then can you do that, or you have to wait?
So at this point, because of so we actually have data from the XVERT study, which looked specifically at cardioversion in patients on NOAC, and this was specific to Rivaroxaban, but it's similar to all of them. We know that the efficacy of the NOAC is instantaneous, within 12 hours. So generally, if you have a patient like this, you can put them on the NOAC in the clinic, arrange for them the next day to have a TE and cardioversion. All this can be done now on the outpatient setting. You don't actually have to keep admitting them, putting them on low molecular weight heparin. There's no need to transmission at all. If you want to put them on an appropriate antiarrhythmic like amiodarone, you can also do that in outpatient setting. So cardioversion is the one that's benefited a lot from the NOAC, and there's a great deal of safety. I would say, though, that unlike warfarin, you cannot test the compliance of the patient. So the only thing about cardioversion is that you generally would do an INR on the day of the procedure. When you look at the INR, you know that the patient took the drug. Now, it cannot guarantee you that there's no thrombus. It only tells you what they did in the last 48 hours. Now, for NOACs, what we have done, and which is a very clever strategy, is you actually tell the patient to take the pill in front of you. So you feed them the pill with a tiny sip of water just before you go ahead and do it, because that you can guarantee that the patient has anticoagulated themselves, because you can measure an APTT, you can get a direct thrombin time or ecurrent thrombin time, clotting time, but it's really a little bit different because you cannot guarantee the compliance pre and post the procedure, right?
Yeah, so patient, you do lots of ablation and device, implantation. What do you do?
Yes.
What's the protocol there? Do you stop there? According to your studies, you don't need to stop them. I don't know. Do you stop them or what? Or?
So generally we don't. As a matter of fact, it's been shown that those have been actually 2 large clinical studies that looked at ablation with interrupted or uninterrupted NOAc. In fact, the risk of bleeding with uninterrupted NOAc is very good. And because we also use ultrasound-guided venous access, we get the access quite well. It's probably safer not to interrupt anticoagulation in a patient who's paroxysmal AFib. You'd reduce the risk of stroke, and there is no increased risk of bleeding. So this was, the outcome of 2 randomized clinical studies with dabigatran as well. So I think we know for a fact that interruption of anticoagulation is not necessary. On the other hand, let's say you do the ablation and God forbid you have a perforation. So the patient actually has full dose NOAc and you've protected them from thrombosis from the ablation side, but they have a perforation. So at that point, if you give them the reversal agent, indracizumab, and you put in your chest tube or your drainage tube and you drain it out and it stops, excellent. If it doesn't, this patient may require an operative intervention to repair the atrium or whatever lesion is perforated. So you still have that backup, but in general, because ablation procedures are really quite safe and we use a lot of technology to help us, including intracardiac echo and so on, it's still preferable not to interrupt anticoagulation in these patients.
Right. So what we've described and what we learned, the safety and efficacy is from randomized clinical trial. But to see how things works in real life is you need another way of. So that's most of our patients, me and Dr. Hani and the rest of our colleagues here, these are not not being included in the randomized clinical trial, and that's the beauty of the real life study, because this is we have actually for these NOACs we have now real life studies and exactly it's consistent in terms of effectiveness and the safety with the randomized clinical trial, which is really a reassurance. And these are some of the results. Maybe one day we'll have time to go through it, but just to tell you, because sometimes people say, okay, randomized clinical trial is very narrowed, it's so burden on the patients, kind of too much, kind of follow up and very restricted. But real life is, more, we are so kind of flexible and we don't look at this and that. But, at the end of the day, this medication showed the effectiveness consistent with randomized clinical trials. And this is the kind of conclusion of, what a randomized clinical trial shows. So I was going to just say because we changed the program today, try to make it very broad because, to take a patient as a whole journey, you don't see it sometimes in an event like this, but I thought it's maybe more beneficial if we do it in this way, at least once every 2 or 3 months, just to keep the patient in relevant and make us a stimulant to think from every aspect. And I think Dr. Hani tackled all the one question people always raise during the COVID and anticoagulations and NOACs, and I know people always trying to defend. They say, okay, there's no evidence for NOACs. I'm sure there's no evidence for warfarin. There's no evidence for heparin because COVID is a new thing to us. So what should we do? I mean, those who are on NOAC, should we stop it? Should we continue? Just take us through that scenario as well.
A brilliant question. In fact, I think the most important thing to realize is that during COVID, our objective has always been to treat patients and avoid them having to have contact with the hospital or get crowding in the lab and so on. So, as a matter of fact, it's probably safer to put the patient on a NOAc knowing their kidney function. So this will basically put them in that protected zone where they are less likely to have bleeding and complications meaning coming to the hospital, and less likely to have need to follow up in the INR clinic and stay in a line and do all of this thing. And if I can just share with you, I found this just a few minutes before we started our seminar. This is a position statement from the Australian Society on Commission on Healthcare Quality. And basically there's a recommendation that in order to avoid pathology clinics during these periods, the use of either home INR monitoring or switching to NOACs where appropriate, right? So I think this is really very important, because I think the main concept we're trying to do is to provide, service while not compromising healthcare. Is it visible or no?
No, I don't see it.
Okay, I just need to. Magdi, if you can just come off the Mu'taz.
Yeah, now we can share.
So this is from the Australian Society Commission of Safety and Quality in Healthcare. Again, reducing the switching from warfarin is a consideration. Obviously, you can't do that with valvular heart patients. Home INR testing and reducing the number of visits if the patient is stable. So I think, as Dr. Abdullah mentioned, we have to make a compromise. We're learning this horrible disease. We know that we try to minimize our contact, but at the same time, there are some basic ways that we can reduce the patient's likelihood of having a complication of Afib or a complication of bleeding.
Great. So, in your practice, you've anybody came back to you? They call. I have a clinic in private. Nowadays, the people on warfarin, we just try to say to them, okay, you stay longer before you come for INR test. But in private, they open. So what's happening in Cleveland? Are you doing the same for people on warfarin?
So our warfarin clinic is actually run by a group of very competent clinical pharmacists, assisted by the cardiologist and the internal medicine people. And they've basically systematically gone through lists of patients who could be switched, who have a indication that's reasonable to switch, so maybe VTE, AFib, non-valvular AFib, and appropriate kidney function, and they've made that decision in conjunction with the cardiologist. So I've received many phone calls during the last 3 months from our really smart clinical pharmacists. I think we have 5 or 6 patients of yours, Dr. Hani, can we switch them? Any question of any contraindication or anything like that? So that's happened. We've also done this strategy of the quick INR check, so the finger check instead of going to the lab, right? Okay. And then we tell the patient, just go home, do the blood test, go home. So for the valve patients, go home, we'll call you, right? We've also been a little bit more flexible. Normally, we would not have accepted to have the patient do an outside lab and call us. But now, in order to minimize travel and reduce the travel restrictions, we tell patients to go to, patients from Northern Emirates or so on, they go to any lab, they send us the result by email or WhatsApp or phone, and then we verify with them the dose by taking a picture of the warfarin dose if we need to, and then we make an adjustment. So, as we said, we can use telemedicine and social media to our advantage in this difficult situation.
Yeah, I think we are learning, to be honest with you. It's just, it's been a nice, I know it's had disadvantage, but I think there are lots of advantage of, COVID. But hopefully we come over this. But I think webinar will continue. I think we'll improve even further in future. We can have more interactions with I'd love to see the audience, participants. Today we had about 176 participants, and that's I think great. But nice to see them interact with us. Maybe in future we're able to improve our technology and do that.
Exactly.
So with that, Dr. Hani, I'd like to really thank you and thank the Inr Cardiac Society for supporting this event. And we have lots of meetings coming. So stay tuned, please, and thank the ICOM for making this wonderful, beautiful, platform. So they are also learning. So this is actually an advanced way of doing it. Before it was different, now it's much better. So great. Thank you very much to ICOM. Thank you. Have a nice day.
Thank you very much.